Hi, my name's Peter Schneider. I'm a vascular surgeon at the University of California at San Francisco. And today I'm speaking with Dr. Ted Gifford, who's a vascular surgeon at Hartford Healthcare in Hartford, Connecticut. And Dr. Gifford has just recently authored and presented a study on pedal angioplasty using the serration balloon. And so today I was going to ask him about that because this really is a novel technique. So, Ted, Dr. Gifford, tell me, in this particular study that you did with serration angioplasty of the pedal arteries, could you give us the nutshell, the highlights?
Sure. So firstly, Peter, thank you. It's a great opportunity for us to be able to talk about this really complex problem. We noticed that patients that we treat with tibial disease, it often doesn't stop at the ankle joint, right? It goes below. And we have very limited options with which we can treat these patients. It's an area where we don't want to cause a vessel injury, and we found serration angioplasty to be really effective for these patients. So we got together a group of investigators both in the US and in Germany, and we looked retrospectively back at our results using serration angioplasty below the ankle joint. And then we've been able to report those results here, which have been quite favorable thus far.
Excellent, excellent. So why is this different? Why haven't we heard about other modified balloons or specialty balloons being used in the pedal arteries?
I think that you have two real problems when it comes to pedal artery intervention. One is deliverable. Can you deliver something to that anatomical bed? You have to go through sometimes calcified, tortuous tibial vessels to get down below the ankle joint. And the big thing is safety. This is an area where if you cause an on-table vessel injury, it can be catastrophic for the patient and result in major amputation. And some of the unique features of the Serinator balloon with the serrated angioplasty, I think, lend themselves very well to pedal artery intervention. For instance, we know that these individual point tips along the serrated strips, they can apply up to 1,000 times greater force than plain balloon angioplasty, but you can do this at atmosphere inflations of 4 to 6 atmospheres on your insufflator, really low pressure inflations.
So sounds like the mechanism of action is different in this case. So you mentioned the high force delivered by the point of each serration. I'm taking it. Is that correct?
That's exactly right. So if you think about plain balloon angioplasty, it's kind of non-specific delivery of pressure. And sometimes in order to get plaque fracture, plaque rupture, which we want to achieve to get luminal gain, you're putting an insufflator up to 20 atmospheres. You can get barotrauma, you can get severe dissection and vessel spasm. And what we found with the serrated angioplasty is that we can go up to 4 atmospheres. We can get nominal balloon sizing at 2.5 to 3.5 millimeters, and that along those serrated strips we're delivering energy in a very focused fashion. And we find that angiographically, at least, that seems to give us very good results with very, very low likelihood of vessel injury.
And does this mechanism of action give you some leeway on your choice of diameter, balloon to artery ratio, or how do you decide that? How does that work?
I think that that's really one of the barriers that we've had in terms of plain balloon angioplasty prior to this. Again, if our first goal in trying to treat these patients is to do no harm, we don't want to use something that we think is too aggressive and is going to injure the vessel. 2 millimeters, 1.5 millimeters realistically probably isn't doing much when we're using it below the ankle joint. Here, we're able to go closer to the actual true vessel size. And so whether we're using IVUS or angiography to try to size that, we're starting off at a 2.5 millimeter diameter serrated balloon and going up from there. We found that in this study, 10 different patients were treated with a combination of 3 millimeter and 3.5 millimeter balloons successfully below the ankle, which is pretty remarkable.
And can you just give me a sense of what you're thinking about flow in the pedal loop and how it may correlate with that little bit larger sized serration angioplasty you're able to do?
I think that this is, again, it really highlights the difficulty in treating patients with chronic limb-threatening ischemia. We have to give them not only an efficacious result at the time of treatment, but it's got to be durable. It's got to be something that's going to get them to heal that wound, because it's not just going to heal on the table, right? I think that the luminal gain that we see with serration angioplasty is both really effective and also seems to be very durable. These patients had over 90% freedom from reintervention within the pedal vessels within this study, and again, 97% freedom from major amputation at our most recent follow-up, which is pretty remarkable in a very high-risk patient population.
So, and prior to the development of serration angioplasty, what would your usual approach have been when disease extended into the foot or into the pedal arteries?
So my standard algorithm is pretty much plain balloon below the knee up until I started using serration technology. There weren't really other good options available. And personally, again, I felt like the risk of vessel trauma was so high I didn't want to cause on-table issues for that patient. I've been so reassured by both my own results as well as the results of all the investigators in this study that I've become much more aggressive going below the ankle and giving patients really good luminal gain, both angiographically but also clinically. You know, seeing them heal their wounds, there's nothing more rewarding than having a palpable pulse at the end of a procedure.
Yeah, that makes sense. So could you give me a snippet on the wound healing that you found in this series and the limb salvage and maybe some hard endpoints like
Sure.
that?
So our major endpoints for this study were, our primary endpoint was technical success. We wanted to see, is this even feasible? Because when we look through the literature, there's nothing that's been described like this at all. And so we chose to define technical success as freedom from vessel injury or less than 50% residual stenosis. And we found that there were 0 events of vessel injury. So 0 embolizations, 0 perforations, 0 significant dissections as measured by our investigators, and obviously no role and no need for bailout stenting. We found 1 patient that had a residual stenosis of 50%, but overall in the 33 patients treated, the post-treatment visual estimated stenosis was 10%. And then clinically, when we followed these patients, we found that again, at 5 months, only 1 patient had undergone major amputation. So we had a 97% freedom from major amputation. Our other outcomes that we looked at were the need for retreatment. So within the pedal vasculature, that was less than 10%, 9%. When you look overall at this cohort, we recognize that the need for retreatment is going to be there. So about 27% of patients had a retreatment within the ipsilateral limb. But overall, at 5 months, our wound healing rates were either completely healed or healing in 89% of patients.
Okay, I understand. So, now that you have shown that serration angioplasty is feasible in the pedal arteries and you got good results in this initial series, what's your next step? How can we learn more about this, do you think?
So I think the first thing we should do is continue to look at these patients. You know, I think ideally continue to kind of enroll more of this data. This is not something I think we're ever going to be able to randomize to. It's too complex of a problem. It's a subset of a subset. But we know it's a big proportion of patients within our CLTI population. I think what we'd like to do is collect some of this data prospectively, so whether that's in a registry format or some other way where our investigators are keeping track of some of these on-table endpoints as well as the clinical endpoints. Really, what we've seen thus far is phenomenal clinical data. We'd like to see that borne out in a larger fashion.
So, Dr. Gifford, how do the results of this study inform a real-world algorithm? I mean, maybe you could describe what you do and tell me what you see happening in the other centers.
Well, I think that the value of this study really speaks to the real-world needs of our patients. You know, as a vascular surgeon, I like to use all the tools in my toolbox. So whether that's bypass for patients that have good conduit, whether it's advanced endovascular therapies, we recognize that patients that have intrinsic pedal disease have very limited options available to them to be able to improve the blood flow in that anatomic distribution. So for me now, it's just such a benefit having a particular tool that we've shown, at least in this study, to be safe and very effective for this difficult to treat patient population. And I found myself and also the other investigators have been clamoring to add more patients because they've found themselves using it again and again in the same fashion.
Yeah. Now, does it make sense to use plain balloon first, see what the results are, and then decide if you need serration, or do you go straight to a serration angioplasty?
I think it's lesion specific as well as some of your approach techniques. So, you know, whether you're going ipsilateral antegrade to try to get pushability or the shortest distance down to those pedal vessels, I think as you become familiar with this technology, you get a good sense for which lesions are going to yield very nicely to serration angioplasty, and I will use that as primary therapy. There are certain cases that have advanced multi-level disease, and I may use plain balloon, and investigators did in this study use plain balloon as an adjunct to serration. But I look at serration angioplasty as more of a definitive therapy. I think plain balloon is a little bit of what we would call vessel prep. You know, it's something to kind of get us to where we want to be, but I don't think that it gives us the luminal gain that we hope to see and that we have seen with Serenator.